Thank you for joining us for this on-demand webinar, Foot Anatomy and the Sonographic Protocol to Assess the Foot, presented by Sarah Baker. Sarah Baker is the Clinical Education Coordinator for the University of Wisconsin Hospital and Clinics School of Diagnostic Medical Sonography. Sarah has been a registered diagnostic medical sonographer and registered vascular technologist for 13 years, working directly in the clinical environment for 5 years, and then working in the education sector for the past 8 years. She also has the privilege of still working in the clinical environment on occasion to utilize her musculoskeletal sonography skills. Sarah has an extensive adult education, teaching, and coordinating experience, along with understanding a vast array of web-based learning management systems, LMS, and social media for the use of educational purposes. During her time as an educator, Sarah has found a great desire and passion for education and technology. She currently teaches undergraduate students pursuing a Bachelor of Science degree in biomedical sciences with a submajor in diagnostic medical sonography. She also teaches residents and medical students certain courses and laboratory classes in how to perform sonography. The sonography specialties that she currently teaches include abdomen, vascular, obstetrics, gynecology, pediatric neurosonography, and musculoskeletal.
My name is Sarah Baker, and I am the Clinical Education Coordinator for the General Vascular Sonography students at the University of Wisconsin Hospital and Clinics School of Diagnostic Medical Sonography. I'll be going over with all of you today the foot anatomy and the sonographic protocol to assess the foot. By the end of this lecture, you should be able to understand the different machine settings used for musculoskeletal sonography and what these settings do to help improve the image when scanning the foot. You should also be able to demonstrate the orientation of the sonographic image. Also understand some basic but essential sonographic artifacts. You'll then be able to identify different musculoskeletal structures related to the foot and how they appear sonographically. We'll then be moving into the indications for performing a foot ultrasound, and then identifying the anatomy in the foot and what is seen on both the dorsal and plantar aspects. We'll also be discussing what should be interrogated with the foot sonographic protocol and the patient positioning in order to see these anatomical structures in the foot. So let's start our journey, which it may feel like one that we're going down the yellow brick road to get to Oz by the time we get done with this lecture, mainly because there is so much information to kind of go over regarding the foot anatomy, but we'll get through it together. Let's start first with the ultrasound machine and the knobs that you'll need to use to better utilize your image. First, we'll be using a linear array transducer. As we know, these are high-resolution probes with a rectangular footprint. The frequency ranges on these transducers can be anywhere from 7 to 18 megahertz, and the uses for linear transducers are various, and they include looking at musculoskeletal structures like the foot, different superficial structures such as the breast, thyroid, and scrotum, as well as vascular structures. But again, these probes will be used for most, if not all, foot examinations. Regarding transmit frequency, current broadband transducers are capable of operating at a range of frequencies, as all of us know. And you'll see on some transducers a range of frequencies listed. For example, on some probes you may see something that says L6 to 10, which would mean the frequency range is from 6 to 10 megahertz, or others may only have a frequency noted on the transducer, and typically this is the midpoint of the frequency range for that probe. Remember that the higher the frequency, the better the resolution, but poorer the image penetration. And the lower the frequency, the better the penetration, but our image resolution will suffer. Again, they're inversely related. So pick the probe that will ideally give you the penetration that you need. So this image here on the right-hand side is showing you the long left first metatarsal phalangeal joint, and the tendon that's going along top of it is the flexor hallucis longus. And this will be showing our frequency range at 12 megahertz, which is the most optimal for this type of imaging study. So this is the optimal frequency that you'll want to use. But as we know, we can use different frequencies. So we're using 12 here on the left side of the image, and now we bumped it down to 5. And you can see that our image resolution has gone down a little bit by lowering our frequency. Moving on to display depth, this allows the sonographer to adjust the image depth to best visualize the area of interest. Depth normally is set at least a centimeter or a touch more beyond the deepest portion of the area of interest. And once we see this area globally, then we can zoom in on the key area that we want to be looking at. Depth also alters our frame rate, so how fast or slow the image is moving. And as our depth is increased, more time is required for that sound pulse to travel to and return back from the maximum depth, so then our frame rate will then decrease. This is showing you here on the image on the left-hand side too much depth, and this is at 3.5 centimeters. By bumping it up just to 2.5, we're looking at the image in a more appropriate depth range. Moving on now to magnification, read versus write zoom. Magnifying an area of interest can help, especially if one needs to see something deep in the body. But with MSK ultrasound, we typically have sonographers decrease our depth as much as possible and then maybe utilize the zoom function if the depth can't be decreased anymore. So our read zoom is a post-processing function that can be utilized after the image is frozen, and it does not have as good of resolution as the pixel number doesn't change, whereas write zoom is a pre-processing function where our sonographer will select the zoom button, a box pops onto the screen, and then the sonographer places the box over the area of interest and then selects the zoom button again, and then we'll zoom up on that image. This reassigns an increased number of pixels to the scanned region during data acquisition, giving us a bit better resolution. You can see here that on the image on the left is an example of a write zoom image, and the image on the right is read zoom. And you can see the read zoom image is a bit pixelier, if that's a word, compared to the write zoom. Moving on now to focal zones and multiple focal zones. So the sound beam has a beam width, and then that beam will also diverge. So our focal zone should be set at or slightly below the area of interest, as it improves the lateral resolution at this point. I like to think of it as the beam sweet spot, and then we're also kind of tailoring that sound beam in to be narrow where we want it to be narrow. By utilizing multiple focal zones, this can improve your resolution at multiple points, but it will slow down your frame rate. So that's something you have to keep in mind. For MSK structures, most of the time, depending on if you're doing something dynamic or not, if you're doing something where it's just for still imaging, 2 would be totally appropriate, maybe even 3 focal zones. If you're doing something that's more dynamic in nature, you'll probably want to just keep it at 1 focal zone to increase that temporal resolution. These are all examples of focal zone placement. The image on the upper left is showing you proper focal zone placement, where we can see that the focal zone, there's only one, but it's set right at the level of our tendon. Moving down to the lower left image, we can see that the focal zone is set improperly and it's set too deep. And then the image more in the bottom middle is showing where the focal zone is set too high. And then the upper right hand image is showing you multiple focal zones that are being utilized here. Overall gain. This is going to amplify the received sound signals equally throughout the image, and the control is used for either increasing or decreasing the overall brightness of the image. So you can see here on the upper middle image, you can see that the gain is way overgained and the gain is too high. It's way too bright. The image on the upper right is too low and it's too dark. So that is just what we want to keep in mind, that it should be set right in the middle. Distance and area measurements. We'll be using different measurements within the foot, primarily to look at the plantar fascia. We'll be looking at measuring any Morton's neuromas, anything like that. You need to make sure that your transducer has good contact with the skin and that you can see all of the borders of the structure that you're measuring. So just keep all of that in mind. We can also utilize the power Doppler function. It'll use the signal strength of a moving reflector to display on the image, and it is qualitative, as we know. These are showing you different examples of power Doppler that has been used in the foot. The uppermost image is showing vascularity in a plantar fascia fibroma, and the 2 images on the more middle to bottom of the slide are showing you an abscess in the foot with marked increase in vascularity around that abscess wall. We can also utilize Doppler gain. This is also amplifying the received Doppler signal equally throughout the power Doppler image. So you can see that the image on the upper middle is the appropriate gain setting. And if we overgained, we can make it look as though the tendon has hyperemia, which would be a false positive. So you want to make sure that your overall Doppler gain is set also appropriately. We use dual screen in a lot of different things in MSK, but we do also do it in the foot. And this is for looking at plantar fascia comparison, which is noted in the bottom two images. And we can also look for compression purposes for a Morton's neuroma versus a bursitis, and that is in the upper two images. The upper two is showing over here on the image on the more left-hand side. We're looking at an interspace at the second and third area of the foot, and we can see that this area is more hypoechoic. It's hard to determine if this truly is a neuroma or if it's just bursitis. So we compress, and we can see that there's a nerve right here, and there is still residual hypoechoic area that is not going away. So we're thinking that that smaller area is the neuroma with adjacent bursitis. We can also utilize panoramic imaging or extended field of view, and this is used when we cannot see a structure entirely on the screen. We use it in MSK for plantar fascia assessment, which is what we're noting here in this image. We can also use it for the lateral hip and posterior shoulder. Moving on now to holding the probe and image orientation. Taming the probe, I'm not going to belabor this because I'm assuming most of us are sonographers viewing this presentation, but as you know, you'll need to hold the probe properly in order to manipulate the transducer and have complete control. So make sure to hold the probe closer to the base and not up higher at the handle or the cord. You'll want to utilize your probe as almost like it's a writing utensil. You need to hold it more close to the tip, not at the end of it. With image orientation in relationship to the notch, as we all know, is our indicator of how the probe is positioned. And typically in the long axis, the notch is pointing towards the patient's head. So proximal structures are located more on the left-hand side of the image and distal structures are more on the right. Then in the trans or short axis, the notch is pointing towards the patient's right side. The left is usually more towards the patient's right-hand side, which could be more lateral or medial depending on what it is that you're scanning. You don't have to keep this order, but most sonographers I think do. This is showing you here an image of the plantar fascia. So you can see here that the notch is pointing technically up towards the ceiling, but this is more towards the proximal end of the foot. So this is being reflective in our image. This is the calcaneus, which is the more proximal end of the foot compared to the distal end of the plantar fascia. This is another example of the proximal aspect of structures being on the left-hand side of the image and distal being on the right. This is showing an example of the anterior foot where we see the notches pointing up towards the patient's proximal surface. So this is where we see the talus, the navicular, the mid-cuneiform, and then the second metatarsal bones as we move more distally. The caveat to this is when we image the toes. So you can see that when we image the toes, our notch is actually pointing up towards the ceiling, but up towards the ceiling is getting to more the distal aspect. So now distal is on the left-hand side and the proximal aspect of the foot is on the right. So just keep that in mind. Moving on to basic but essential scanning artifacts that we'll need to know when scanning the foot in most MSK structures. By looking at artifacts, they're important to know and understand. By not knowing them, we could cause a misdiagnosis, and by knowing them, we can help confirm a type of pathology or a normal structure. So these are just some basic artifacts you should become familiar with when scanning MSK structures, and especially in the foot. Anisotropy is usually a very large artifact that happens, and when I say large, meaning that it happens often. This occurs when the probe is angled slightly off of the perpendicular axis of the musculoskeletal structure, which causes that structure to be more hypoechoic than what it normally would be. So you need to decide if something is scanned improperly or if it's truly pathology. These are examples of anisotropy. These are showing you examples here in the shoulder of the distal supraspinatus tendon in the shoulder. We can see here that this could easily be confused as a tear, but we adjust the probe such that we're now more perpendicular to that tendon and we're clearing out that hypoechoic nature that we were seeing, and that's just simply anisotropy. This is moving now into the lateral ankle of the anterior talofibular ligament. This is showing the anisotropy effect where we're more hypoechoic. We adjust our probe, make that ligament more perpendicular to our transducer, and now we're making it more hyperechoic. This is another example in the medial ankle of the posterior tibialis and flexor digitorum longus tendons. This is showing you here anisotropy. We're getting both of these tendons to be very hypoechoic. That's not how they should appear. They should be nice and bright and hyperechoic. By adjusting our probe and angling, we're able to brighten both of these up beautifully, and that is, again, just artifact. Another artifact we can see is posterior enhancement, also known as through transmission. As we know, it's characteristic of fluid-filled structures, and when the sound beam travels through fluid, the echoes behind the fluid become brighter than the normal surrounding structures. So these are all examples of that. The bottom left here, we're showing fluid in the posterior ankle joint. We can see here's the talus, here's the calcaneus. We see this area of fluid, and we're getting a little bit of enhancement behind it. The upper right-hand image here is showing alcohol ablation of a neuroma or fluid in the third interspace of the plantar foot. By injecting this alcohol or fluid, we're going to be getting a little bit of posterior enhancement behind it. This is showing a ganglion cyst in the foot. So the cyst, again, is going to be anechoic with that posterior enhancement behind it. Shadowing is the opposite of enhancement. This is where the sound beam is completely reflected or absorbed or attenuated by the structure being imaged, and shadowing indicates that the sound can't penetrate through the structure. We can also get shadowing when gas or air-filled structures are present. This example here is just showing shadow behind the bones of the fourth metatarsal and fourth phalanx. We can see that these bones right here are going to be hyperechoic on the surface, but then a lot of shadowing behind it. Refraction is a type of shadowing that results from bending of the sound beam. We can sometimes see it on the edges of a cyst. In this example here, this is showing the Achilles tendon with a full thickness tear, and this is demonstrating refractile shadowing. Reverberation, this is where the sound signal is bouncing off of a strong reflective interface, and it's seen as parallel lines in the near field of that fluid-filled structure. We can also get comet tail, which is ring down artifact, which is another type of reverberation that we can see sometimes adjacent to surgical clips, air, or certain types of pathology. And we see this as multiple parallel spiral lines. The uppermost image here is showing just your classic reverberation in that ganglion cyst in the foot. And then the bottom image here is showing a patient with a hip replacement that's demonstrating ring down artifact behind the metal surface. Now we can go on to normal foot structures and how they appear sonographically. First thing are tendons. Tendons are more hyperechoic with a fibrillar pattern is what they're characterized as, and this is, in other words, known as fibrous. Tendons that we'll see in the foot are going to include the flexor hallucis longus tendon, the flexor digitorum longus. We saw this when we were talking about frequencies several slides ago. This is showing you here that tendon. We can see the anterior tibialis tendon. This is demonstrated in the middle image right here. And then the bottom image is showing you the extensor digitorum longus. We can also see the extensor hallucis longus on the dorsal surface. Ligaments are hyperechoic and they're striated, and when you compare them to tendons, they are more compact. The ligaments that we may see in the foot on the dorsal side include the calcaneocuboid, which is between the calcaneus and the cuboid bones, which we can see that up in this top image here. We can see the talonavicular. We can also see the Liz-Frank ligaments, which is what's demonstrated here and in this more anatomical diagram here. On the plantar side, we can see the accessory and proper collateral and the inner transverse ligaments, and this is just showing you here a diagram of what or where those ligaments are located. Muscles are going to be more hypoechoic, and muscle bundles can be surrounded by hyperechoic structures known as fibroadipose septa. Muscle examples in the foot on the dorsal surface are going to be the extensor muscles, which are depicted here in this diagram. On the plantar surface, there are several. We can see the abductor hallucis, we can see the flexor digitorum brevis, the abductor digiti minimi, and the adductor hallucis. This example here sonographically is showing you some of those plantar muscles, showing you the flexor digitorum brevis, the abductor digiti minimi, which is on this side, and the adductor hallucis on this side. Nerves have what we call a fascicular appearance. The nerve fascicles are hypoechoic, and they're surrounded by hyperechoic connective tissue. They have almost a honeycomb-like appearance in transverse, and that's how you're going to be able to spot them. These are showing you several of the nerves that we can find in the foot. This sonographic image is showing you that kind of classic honeycomb appearance, and again, we see that honeycomb appearance in the transverse plane. This is showing you both the medial plantar nerve and the lateral plantar nerve. Joint spaces, this is just the space between bones, and it's hypoechoic to anechoic, and it's seen between two bone areas. These are showing you here the joint spaces between the proximal phalanx and the metatarsal, and these are showing you the joint spaces between the talus and the navicular, and also between the navicular and the mid-cuneiform and the second metatarsal. We can see all of these little joint spaces that are hypo to anechoic. Bone, the surface is going to be hyperechoic, and then posterior shadowing or reverberation will be past that hyperechoic surface. The bones that we can see in the foot are numerous. They can include the calcaneus, the navicular, the talus, cuneiform, cuboid, metatarsal, and phalanges. And this is the same image that I just showed the slide prior to show how hyperechoic bone surfaces are, and then the shadowing that goes on behind it. Cartilage, we can see both hyaline cartilage and fibrocartilage. The hyaline cartilage covers the articular surface of the bone, and in this example here we're seeing it with the green arrow, this hypoechoic line. Fibrocartilage is more hyperechoic in contrast. An example in the foot would be the plantar plates, which is what we're seeing here with the green circle. It's a little bit more hyperechoic, and it's a plantar plate. Fascia are thin fibrous tissues, and they enclose either a muscle or organ, and the fascia that we're going to be seeing more commonly in the foot is the plantar fascia. It's hyperechoic. It's isoechoic in comparison to tendons and ligaments, but overall it's a hyperechoic structure with a linear fibrous appearance. And this is a beautiful panoramic image showing you the plantar fascia extending across this field here. Bursa is the cushion between the bone and a moving part, so the muscle, tendon, or joint, and it can contain fluid. Commonly seen bursa in the foot are the metatarsal bursae, which are in between the toes or the inner spaces, and we evaluate these areas for bursitis because that can be quite painful for patients. The example here in the bottom dual sonographic image is showing you the left second inner space of the foot, and we can see this area that's hypoechoic in nature. There is a nerve kind of coursing right by it, and we wonder, is this area a neuroma or bursitis? And if the area compresses and moves and is gone with compression, we know that it's going to be bursitis. A neuroma will persist. So we can see that as we compress, here's the nerve here, we don't get that same hypoechoic area. It completely compressed out, and therefore it was bursitis. Moving on now to anatomy of the foot. Indications are pain, palpable area, an evaluation of the tarsal joints, plantar plates, bursitis, Morton's neuroma, plantar fasciitis, and looking also for plantar fascia fibromas. The foot anatomy is quite complex, given that it's sort of a smallish area. And during this whole talk, I'll attempt to simplify by going over the anatomy in sections. And these sections are going to be bones and joints, ligaments and tendons, muscles, nerves, and blood vessels. So let's start with bones and joints. In the foot, there are roughly 26 bones that are located in the foot, and these bones include the talus and the calcaneus, which are here and here. I'm going to look at it on this, here and here, and they comprise the hind foot. We have then the navicular, cuboid, and the three cuneiform bones, the lateral, medial, and intermediate, which comprise the midfoot, which we can see the navicular, the cuneiform bones, and we also have the cuboid, and these all comprise the midfoot. We also have the metatarsal and the phalangeal bones, and these comprise the forefoot. So here are all of the metatarsal bones and then all of the phalanges. The great toe, also known as the hallux, only has two phalanges and one interphalangeal joint. You may also see two sesamoid bones located on the plantar aspect of the MTP joint or the metatarsal phalangeal joint, and a sesamoid bone is embedded in a tendon, so you'll see those. Moving on to joints, there are 33 joints that are located in the foot and in the ankle. On the dorsal and plantar side, you're going to see roughly the same ones. You'll see the first to the fifth metatarsal phalangeal joints, which are located in these circular areas here. We'll see the first to the third tarso-metatarsal joints. You can also call these the Liz-Frank joints right in here. The fourth through the fifth cuboid metatarsal joints out here. The intermetatarsal joints, the cuboido-navicular joint, and then the transverse talar joint, which is comprised of the cuneo-navicular joint, the calcaneo-cuboid joint, and the talo-navicular joint, all that are located within the dorsal and plantar aspects of the foot that you can see circled here. These same joints can also be seen on the plantar surface, so keep that in mind, and this is just showing you here the plantar aspect of the foot with all of these same ligaments that were listed on the slide prior. On the lateral side, we can also include now the ankle joint that we can see the subtalar joint, and then we can also see the proximal and distal interphalangeal joints, also known as the PIP and the DIP. So that's where all of these are located here. On the medial side, we can see the interphalangeal joint of the great toe and the cuneo-navicular joint. Moving on now to ligaments and tendons. There are several also in the foot that we'll be trying to cover in a simplistic fashion. In the foot, the ligaments of particular interest are going to include the dorsal talonavicular, which in the diagram here is going to be located in this area. The bifurcated ligament, which comprises of the calcaneo-cuboid and the calcaneo-navicular, and this is located in this region right in here. And then the Liz-Frank, which we're going to be seeing that more on an area that we're not able to see on these diagrams here, but those are also the ligaments we'll be looking at. There are also several tendons that we can view in the foot on the medial, dorsal, lateral, and plantar aspect, and we'll go through each of these individually. On the medial or plantar aspect, or medial to plantar aspect, we're going to see three flexor tendons that will evaluate from anterior to posterior, and these include the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. They travel through this tarsal tunnel on the medial aspect of the ankle, and the structures from anterior to posterior can really be best remembered by using the acronym Tom, Dick, and Very Nervous Harry, where Tom, or the T, stands for the tibialis posterior tendon, which is located right here. The D stands for the flexor digitorum longus tendon, which is located at the next arrow right over here. The and Very Nervous Harry, the A stands for artery, the posterior tibial artery. The vein stands for the tibial veins, and then the N is for the tibial nerve bundle, which is all right in here. And then Harry, or H, stands for the flexor hallucis longus tendon, which is over here. So by trying to keep this acronym in mind, it might help you in remembering the order of these very long named tendons. So now going through each of these tendons individually. The posterior tibialis tendon originates in the tibia fibula in the interosseous membrane, and it courses beneath the medial malleolus, inserting onto the tuberosity of the navicular bone, and it will send extensions to three of the cuneiforms and the bases of the first to the fourth metatarsals, and it's our primary inverter of the foot. So if we look here at the posterior tibial tendon, we're going to see it back here, extending down along the medial aspect of the foot, going more towards the plantar portion of the foot. The flexor digitorum longus tendon originates at the tibia, laying immediately superficial to a structure known as the sustentaculum tali, and this is right in here. The flexor digitorum longus tendon is going to be located right in this region on this diagram. It passes lateral to the tibialis posterior tendon. Again, this is going to be our D for Dick. So we had Tom already, now we're on to Dick, inserting onto the distal phalanges of the second through the fifth digits. This is showing you an example here of the third metatarsal phalangeal joint area, where we can see the third flexor digitorum longus tendon extending over right in this region, and this is how we would look at it with the probe. Moving on now to Harry for the flexor hallucis longus tendon. This originates also at the tibia, most posterior of all of the three flexor tendons, inserting on the base of the distal phalanx of the first digit. If there are issues seeing this tendon, which there very well could be, you can confirm that the FHL tendon is truly what it is by wiggling the first toe. So this is showing you here in the diagram the flexor hallucis longus tendon In here, it's also in here. You can see it right there and on this end. And by wiggling the toe, which I'll show here next, we can confirm that it truly is the FHL. So by playing this here, this is in transverse, and we're able to see that tendon beautifully here wiggling when we wiggle that first toe. In longitudinal, you're seeing it here, and we're moving that large first toe. We're able to move that tendon to confirm that truly is FHL. And this is showing the flexor hallucis longus tendon in relationship to the first metatarsal phalangeal joint. So this is showing you it right here and how we would obtain that image by placing the probe right along that first toe. The knot of Henry, this is where the flexor digitorum longus and the flexor hallucis longus tendon cross over each other before going to their distal destination insertion points. We look at both of these tendons at the crossing. So if we look here on the upper diagram, this is showing you where they're crossing each other. We have the flexor hallucis longus, flexor digitorum, they cross, and then they go to their distal destination points. This is showing it more sonographically. It's a bit more subtle than the diagram. The arrowheads here are showing the flexor digitorum longus. The arrows are showing the flexor hallucis longus, and then the curved arrows are showing where they cross, and this is that knot of Henry. Moving on now to the dorsal aspect. Now there are 3 extensor tendons that we'll be evaluating from the medial to lateral aspect of the dorsal aspect of the foot. These include the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus, also known as Tom Hatestick for an acronym to hopefully make it make more sense, where T is again the anterior tibialis, H is the extensor hallucis longus, and then D is the extensor digitorum longus. We can see them here in the non-kind of labeled image up here, and this is how we would place our probe to see those tendons. The tibialis anterior tendon is the largest and it is the most medial. It can be palpated as a cord-like structure, and it will insert onto the medial cuneiform and the plantar aspect of the base of the first metatarsal. This is responsible for dorsiflexion and inversion of the ankle and foot, and we can see it here along the dorsal aspect. And this is also it here. When looking at it sonographically, we would place our probe as this sonographer is in this image, and this is how it would look sonographically. The extensor hallucis longus tendon, this lies between the tibialis anterior and the extensor digitorum longus tendons. It inserts on the dorsal side of the base of the distal phalanx of the first toe with expansions to the base of the proximal phalanx on either side, and it's responsible for dorsal flexion of the ankle and extension of the big toe. So this is showing the extensor hallucis along this aspect right here. And we can also see the extensor hallucis right here. When looking at it sonographically, this is how the sonographer would place the probe over the great toe on the dorsal aspect, and this is how it would appear. Moving on now to the extensor digitorum longus tendon. This passes lateral to the extensor hallucis longus, more flattened appearance, and will divide distally into 4 slips with insertions on the 2nd to the 5th toes. This will be responsible for dorsiflexion of the ankle and extension of the 2nd through the 5th toes. So these are all of the extensor digitorum tendons in here, and we can see them also in this region right here. And on ultrasound, if we were to go through the remaining toes, this is how we would do it, and this is how they would appear. Tendons now in the lateral to plantar aspect. We assess the peroneus longus and the peroneus brevis tendons. The brevis is located at the retromalleolar groove in the transverse plane directly posterior to the fibula. It'll be smaller and a touch more anterior compared to the longus, and the brevis will be followed distally to its insertion on the 5th metatarsal base. So we're looking at the brevis. The brevis is going to be located here and along here. And one of the sonographers that trained me had said, when you're looking at these, think brevis is closer to the bone, and that has helped. And again, it's also smaller. In comparison to the longus, which is adjacent to the peroneus brevis at the level of the retromalleolar groove, it's characterized by a lack of a muscle belly, and this will insert into the first metatarsal base and the medial cuneiform. So this is showing it on the aspect here, and then we can see it along this aspect here. The brevis tendon, this is showing how you would look at it as it's inserting distally to attach the fifth metatarsal, and this is showing its insertion into that bone. And then this is how the peroneus longus is going to insert. You can see how it goes, and it will attach on the underside of the foot. The plantar fascia now is going to be what we're looking at the bottommost aspect of the foot. It's deep to the subcutaneous tissue, and it's a network of compact collagen fibers. It's a dynamic support of longitudinal arches, and it consists of 3 cords. The central cord, which is located in here, is going to be the thickest, the largest, and the strongest. We also have a medial cord and a lateral cord that comprise all of the plantar fascia. So when we're assessing the patient's foot, this is how they will be positioned, not just typically pointing up towards the ceiling. We can see here the proximal aspect of the plantar fascia where the calcaneus is here with the plantar fascia origin. And then this is showing you more of a non-labeled image. Again, this is where the calcaneus lives, and then the proximal plantar fascia is located right in here. Moving on now to muscles. Muscles on the dorsal surface include intrinsic muscles of the short and the long extensors of the toes, which both originate at the superior aspect of the calcaneus. We can see them in this region here. The extensor digitorum brevis, these insert on the lateral sides of the extensor digitorum longus tendons for the second, third, and fourth toes, and these are going to be located in this region here. And then the extensor hallucis brevis will insert into the proximal phalanx of the great toe. And then on the plantar surface, these are grouped into 4 layers of muscles from superficial to deep. I have 2 of the layers listed here for you, but there are a total of 4. If we move from superficial to deep, we'll be seeing the abductor hallucis, the flexor digitorum brevis, and the abductor digiti minimi muscles, which are located in this diagram here. We can see the abductor hallucis, the flexor digitorum brevis is located in here, and the abductor digiti minimi is going to be out here. And then this sonographic image is showing you here the flexor digitorum brevis, the abductor digiti minimi muscle, and the abductor hallucis. Moving more deep, we'll get into the quadratus plantae and the lumbricals, which are located in this diagram here, along with the flexor hallucis brevis, adductor hallucis, and the flexor digiti minimi brevis muscles. As we move even deeper, we'll see then the dorsal and plantar interosseous muscles. And then lastly, we're getting into nerves and arteries. With nerves, on the dorsal side, the sensory supply is going to be by the distal branches of the saphenous nerve and the superficial perineal and sural nerves. And the terminal branches of the deep peroneal nerves are going to supply the first web space. So there's several nerves that can be seen within the foot. On the plantar surface, this is innervated by the medial plantar nerve and the lateral plantar nerve, which are both branches of the tibial nerve. And the calcaneal branches of the tibial and sural nerve help supply the heel. So these are all, again, nerves that we can possibly see in or be asked to look at in the foot. Lastly, our arteries that feed our blood supply to the foot. And the big one is the posterior tibial artery, which is the main blood supply to the foot, which runs right beside the posterior tibial nerve of the same name. The dorsalis pedis runs down the top of the foot, and other kind of, I want to say less important, but they're not as prominent arteries enter the foot from other directions. Now moving on to the foot sonographic protocol. The main areas to evaluate will be the tarsal joints, the ligaments, and the nerves when we're looking at the foot. On the plantar foot, this is going to be more commonly and routinely assessed compared to the dorsal side. And when we're looking at the plantar foot, we're evaluating for things such as a Morton's neuroma, bursitis, looking at the plantar plate, making sure that that's intact, the first to the fifth metatarsal phalangeal joints, the flexor hallucis longus tendon of the first digit, the flexor digitorum longus tendons of the second through the fifth digits. We're also looking for plantar fasciitis as well as for a plantar fascia fibroma. So looking at the plantar foot, so the protocol for looking at or looking for a Morton's neuroma would include in the long axis looking at the first to the fifth metatarsal phalangeal joints. When we're looking at the metatarsal phalangeal joints, we're looking at the flexor hallucis longus tendon that's going to run more superficial to it on the first digit, the flexor digitorum longus tendons from the second through the fifth digits, and we're looking at the plantar plates in all of the digits. Once we're done looking at those regions, we'll then adjust our depth and our focal zones to assess the interspaces of the first through the fourth areas of the foot, and looking for neuroma and bursitis. The reason why it's kind of nice to kind of separate and do the metatarsal phalangeal joints and the bones and the tendons all first is because all of your adjustments in regards to depth and focal zones will be the same pretty much for those structures. Once you then get into the interspaces, you'll have to increase your depth and bring your focal zone a bit deeper to look at the interspaces. We also look at the plantar plates, and these are the fibrocartilaginous structures that insert into the base of the proximal phalanx and extend posterior to cover the cartilage of the plantar aspect of the metatarsal heads. We're looking at them here in this diagram and in this diagram here. The plantar plates are connected on each side with the collateral ligaments and inferiorly with the intermetatarsal ligament. They're the main stabilizers of our MTP joints, and any compromise to the integrity creates instability of the joints. So when we're looking at the plantar plate, this is where we're looking at our MTP kind of joint region and also at our tendon. We can see this triangular region deep to the tendon, and this is going to be our plantar plate. So now looking at each of the metatarsal phalangeal joints, the first MTP is evaluated, and we'll note that the flexor hallucis longus tendon is going to reside as well in this image. We can also note sesamoid bones, again, that we're going to be seeing just at the first toe. We then look at the second to the fourth metatarsal phalangeal joints. We note now that it's now the flexor digitorum longus and the plantar plate on each toe. And for these particular toes, we'll need to perform a dynamic dorsiflexion maneuver to assess the plantar plate and ensure that the plate is intact. So here's an example just of a still image of the metatarsal phalangeal joint with the FDL located along top, and the plantar plate is located here. And then in this cine clip, we can see that we're looking at the plate, making sure that it stays intact and then it looks nice and uniform. The third metatarsal phalangeal joint is next. We can see that it's here. Here's our FDL, and here's our plantar plate. And then we'll do a dynamic evaluation of that plate as well. Moving on to the fourth, again, here's the MTP, the FDL, plantar plate, and then the dynamic assessment. And then moving on to the fifth. The fifth can be more challenging to lay out due to the size and the curvature of this particular toe. So you may have to show the joint and the tendon in one image and the plantar plate in a different image itself. Dorsiflexion is not indicated for the first and the fifth toes, only for the second through the fourth. This is showing you here the right fifth MTP, and we can actually see the FDL along this toe really well, and we can get a little bit of that plate. We can see here's the FDL here, and we're trying to get a little bit of the plate in a separate image. Once we look at all of the MTPs, then we're going to be moving on to the interspaces. So the first to the fourth interspaces are evaluated again for bursitis and for Morton's neuroma. The first and the fourth interspaces rarely will have a neuroma, and they may demonstrate fluid or bursitis. The second and third interspaces are more common locations for a neuroma. And if bursitis or a neuroma is seen, you'll have to do a dual screen image with and without compression maneuvers. And you may also want to take a cine clip of the compression maneuver. If we suspect a neuroma, you'll want to try to visualize that nerve going into this soft tissue mass to help confirm truly that you're seeing a neuroma. And we can also try the Mulder sign and short axis, which I'll attempt to show you in a YouTube video in just a little bit. Compressing the interspaces can be tricky. The probe is on the plantar surface and the other finger is in the interrogating interspace. And you slide dorsally by placing the finger up and down the foot to assess for fluid versus a Morton's neuroma. And most of the time too, it's very easy to have the probe too distal. You have to move the probe down more proximal to really get in that interspace. So this is showing you here an example of the right first to second interspace. You'll see these labeled a little differently. Some will only say right first interspace, some will say right first to second because it's indicating we're in between the first and second toes. It means the same thing. So we're looking here and there really is nothing here that's catching our eye. Same with this as well. We'll want to make sure that we don't have a lot of bone or anything in our image. There's a little bit of bone coming in here and you may lose a little bit of contact. So you'll want to keep that in mind. But overall, both of these look very clean. Moving now into the second interspace, we have several here that are demonstrating either bursitis or Morton's neuroma. In this image here on the left-hand side is a dual screen image. Again, we're looking and we're suspicious of a neuroma. We compress, it compresses all out, so this is just a bursitis. In the upper hand images here, we can see we're curious. This looks quite large. Here's a nerve here, thinking that we're going to be looking at a neuroma. We compress. We get most of this tissue to compress out, which is most likely bursitis with a very small neuroma. This is an example here where we did do compression, and this did not compress out, and this turned out to be a neuroma. And this one is even more confirming, and it's the same patient, by showing the actual nerve going into the soft tissue mass. And this is showing you more some of the dynamic maneuvers that you can do. This is of the right first to second interspace. Trying to demonstrate if there's any kind of fluid in there. Move that around. The right second to third, we're suspicious of a neuroma. And by moving that probe back and forth, you're able to not get too off axis. And if you do get off axis, you're rotating the probe so that way you can get back on axis of the area of interest. So we're moving around and we can see that this area right in here is persisting. This is all squishing out. Bursitis, this is all bursitis in here, and then the neuroma is persisting on this side, and we can see the nerve going right into that soft tissue mass. The third interspace, this is showing it here. This is a nice, normal, relatively clean interspace, as opposed to this one where we can see there's a very large kind of hypo to anechoic area. We do a lot of compression. We're able to squeeze all of that out, and so that's going to be bursitis. Then the fourth to the fifth, usually this is also a pretty clean interspace, nothing going on in either of these images. And then we can do the Mulder's test. If we see a neuroma, we can attempt to visualize the neuroma in the short axis, and by performing this maneuver. You place the probe in transverse over the interspace containing the neuroma, and then you squeeze with your non-scanning hand the mid portion of the foot, as we're seeing right in here. And you may see the neuroma pop into the interspace. This will direct us, or it should, to YouTube. This is showing a neuroma between the third and the fourth, and it'll pop right out like so. You can see that. That's a very impressive one. They're not always this easy to get to do that, but if you can, more power to you. Then we can look at the plantar aspect of the foot, but closer to the calcaneus when we look at the plantar fascia. Typically when you do a foot protocol, if it's just for a Morton's neuroma, we won't be doing a plantar fascia assessment unless it's indicated to do so. Plantar fascia evaluation is typically separate. Same is true if you're looking at the plantar fascia, you typically will look at the more distal aspect of the foot looking for Morton's neuroma. They're separate exams. But when we look at the plantar fascia, we look at it in both the long and the short axis, from proximal to distal. In the long axis, we evaluate the proximal aspect near the calcaneal insertion, which is what we're seeing here and in here. And we do a side-to-side comparison measurement taken at the proximal insertion site of the affected and then the non-affected contralateral side, just for comparison purposes to make sure that they're both symmetric. We can place power Doppler over the plantar fascia to assess for any hyperemia, and in all of these images, these are all showing nice normal examples of the plantar fascia. It's not overly thickened. As you move more distally from the proximal insertion, you'll want to evaluate distally down the foot, and we can obtain a panoramic image of the entire plantar fascia in the long axis, but this is showing you here more mid into the distal aspect of the plantar fascia. These are all consecutive images, moving more from, we've already taken all of our proximal images, these are more moving mid into the distal aspect. We do throw power Doppler on, and then we do a nice panoramic image to show the entire plantar fascia. Then moving into short axis, we can follow the plantar fascia from proximal to distal as well, noting any incidental fibromas or thickening of the plantar fascia. For myself, I can see plantar fibromas a bit better in the short axis, but everyone's a little bit different. And if you can, try to obtain a cine clip of the plantar fascia from proximal to distal. The plantar fascia itself, I think, is harder to see in the short axis. The fibromas are easier, I think, to stand out in the short axis, but the actual plantar fascia itself can be challenging to see in the short axis, especially as we move more distal. So you may have to move back into the long axis to try to kind of get your bearings on where you're at and not get confused on where the plantar fascia is located. So this is showing you here moving along the plantar fascia, moving from proximal to distal. And as you can see, it gets smaller and smaller and more superficial. In these images here on the bottom three are all showing examples of a plantar fascia fibroma. So again, you can see them, I think, a bit better in the short axis plane. When you turn long on them, you can see them too, but you can see them more globally and transverse initially when you're trying to find them. And sometimes these are just found incidentally, but a lot of times patients will actually be able to have a palpated kind of lump on that plantar surface. When you're doing the plantar fascia, you may be also asked just to do a very brief evaluation of the Achilles tendon. You will evaluate, if you have this as a part of your protocol, you may be asked to evaluate the tendon in short and long axis, just in the distal portion of the plantar fascia. And you'll show it inserting into the calcaneus. You won't necessarily do an entire full Achilles protocol like you would if you were worried about the Achilles, but at our institution, that's what our radiologists like to have, just to show it and make sure that that distal insertion site looks good. We'll obtain a power Doppler image to assess for hyperemia, measuring the Achilles tendon in the long axis near the calcaneus, and then doing a dual image of the same spot on the contralateral side. And then we can also do a panoramic image of the entire Achilles, as well as doing a dynamic evaluation where we have the patient perform a dorsiflexion maneuver. And this is just showing you where you place your probe and then how this will look at that distal insertion site. We can also look at the retrocalcaneal bursa. This is located more anterior to the Achilles tendon. Remember, we're coming posterior, so this will all be farther away from us. It's near Kager's fat pad, which is located here with the letter K. We evaluate this area to evaluate for fluid. And we can also look at the subcutaneous calcaneal bursa to look for fluid. And this is located superficial to the Achilles tendon. And so because it is so superficial, you may have to use a large gel pad to see if fluid is present. So in summary, we made it to Oz, and it has been a long journey because the foot anatomy, I think, is so complex. But the pertinent common indications for performing a foot sonographic exam, I think, are pretty straightforward, mainly because the Morton's neuroma exam and the plantar fascia exams are probably going to be your more common exams that you're going to be asked to do. Because of this, you should have a succinct plantar foot protocol for evaluation of Morton's neuroma, as well as for the plantar fascia. But just like anything else in MSK, especially being a more general sonographer background, it really is knowing your anatomy. That is probably the most challenging part of this whole thing, is knowing your anatomy, trying your best to memorize it, have it make sense to you in a way that's easy to do. But you can do it if you want to do it. So good luck as you forge ahead in getting to your Oz. Thank you so much for your time and for listening to this presentation.